Good evening, everyone. Thank you for joining this evening's webinar on managing myeloma, the long-term effects. I think we may have had some IT issues because, as you might have seen, I've been looking at the screen, but hopefully now we're ready to go. So welcome to our Digital Infoday Session. In this webinar, we will talk about later effects for patients who've had myeloma for some time, and we'll go through some common issues and offer helpful and practical tips in dealing with these. The webinar is being recorded and will be available to watch on our Facebook page and website soon afterwards. The structure of this webinar will be a presentation from our speaker and then a question and answer session at the end. If you have a question and perhaps would rather not ask it this evening, or you think of one after the webinar is finished, you can always talk to our your hematology team or get in touch with us via the Myeloma info line or Ask the Nurse service. If during the webinar you'd like to chat with each other, you can use the chat box. And if you have questions for the speaker, please use the Q&A box. Both can be found at the bottom of your screen. So I'm Suzanne and I'm the head of clinical practice services at Myeloma UK. So some of you might not be familiar with Myeloma UK, so I'd like to tell you briefly who we are and what we do. Myeloma UK exists to support all those affected by myeloma and its related conditions, which include smoldering myeloma, MGUS, and AL amyloidosis. We are patient-focused and we aim to empower, inform, and support patients in everything that we do. As an organisation, we rely on the generosity and kindness of supporters. Myeloma UK receives no core governmental funding, so your support is vital, and we are truly thankful for all contributions as they allow us to continue working to help patients, their family, and friends. This evening, I'd like to welcome our expert, Dr. Fenella Willis. So Dr. Willis is a consultant haematologist at St George's Hospital. Thank you for speaking to us this evening, Fenella, and now I'll hand over to you for your presentation.
Many thanks, Suzanne. Hopefully you can see my video. This evening, I really want to be able to talk to you about the common sort of problems that we see later in the disease of myeloma. The aim of our talk is to cover complications myeloma patients have later in their disease, which can be as a result of treatment, complications that occur as a result of the myeloma, and how these complications can be managed. Next slide, please. There are many messages that we will cover today in this talk, but it's always important to pick out what we feel are the key 3 take-home messages. 1, more myeloma patients are living longer these days with better treatment and management. 2, that longer-term myeloma can cause complications as a result of a build-up of treatment side effects and the changing myeloma disease. But importantly, 3, these complications can be managed by the healthcare team. So it's really important to report new symptoms or side effects to your clinicians and nurses so that they can help you with them. Next slide, please. Just as a background in terms of the long term, myeloma, half of patients with myeloma are now surviving their disease for 5 years or more. And around about a third of patients with myeloma will survive their disease for more than 10 years. So we can classify myeloma really as a chronic disease. The 5-year survival for myeloma patients has doubled since the 1990s, and the 10-year survival for myeloma patients has tripled since the 1990s, with the average life expectancy for myeloma patients quadrupling since the 1990s, which is in effect a combination of improvement in treatments and improvement in our supportive care. Next slide, please. So we're going to cover two areas. So first of all is the management of the common complications of treatment. In this slide, you can see obviously our patient is in the center, and the symptoms that we're going to cover are those of fatigue, infections, low blood counts, pain, peripheral neuropathy, and osteonecrosis of the jaw. Next slide, please. Many patients suffer with fatigue. Often the question is, what is fatigue? And that can be a very individual and an individual patient. But fatigue is an overwhelming and often persistent tiredness which affects quality of life. It can result in reduced energy levels, poor concentration, poor sex drive, and reduction in appetite, and can impact on every aspect of a patient's life. Patients may complain that they feel weak or lethargic, and sometimes they comment that they might feel like they're walking through treacle. They might find it very difficult to concentrate, and many patients complain of these symptoms. Many struggle with fatigue even after treatment is finished, and they think that everything should return to normal. Next slide, please. So what causes this symptom of fatigue? Well, it can be a combination of factors. It might be related to the underlying disease or treatment. Sometimes it can be a direct side effect of treatments such as drugs like thalidomide, which has a sedative property, or painkillers, which also may have a sedative property. It can be the long-term effects of being in pain. The combination of infection or reduction in the blood count, particularly anemia, can affect people's energy levels, and also problems with the kidneys, so impairment of the kidney function may affect energy levels. Combined with that, there are also many lifestyle and emotional factors that may affect someone's energy levels and impact in fatigue. Poor diet and dehydration, difficulty in sleeping, reduced energy levels, and just the emotional impact of having myeloma and the ongoing concern about your disease and treatment in the future. Next slide, please. So how do we manage fatigue? Well, it's really important to discuss fatigue with your doctors and nurses so that they can help to look out for possible causes and help to treat and manage them. If you're struggling with anemia, it's possible that you may need a blood transfusion or support with injections such as erythropoietin, which stimulate the production of red blood cells. The management of painkillers is often very important, and that might need some very skilled input from pain experts such as the palliative care team. It might mean altering the painkillers that you're on, and also considering other treatments such as complementary therapies. If there are ongoing problems with kidney function, it may be important, obviously, to look at issues such as dehydration, fluid intake, and management of your kidney disease. And then finally, things such as infection, so making sure that underlying infections are properly managed, and remembering that after infection, often there can be an ongoing issue with fatigue for some weeks or months after you actually have recovered from an infection, and that these may need to be addressed. Your myeloma treatment may need to be adjusted to help with your fatigue, and that's one of the things that may need to be discussed with your clinicians. Next slide, please. How do we live with fatigue? It's very important that patients try to look at ways to help themselves, as well as obviously speaking to their healthcare teams to try and live with fatigue. It's really important to have a good diet, a balanced diet with many fruit and vegetables, and to avoid getting dehydrated. Sleep can often be difficult, and if you're finding it difficult to sleep, it might be worth considering having small naps during the day to try and rest, but also trying to develop a good sleep pattern such that you try and avoid things such as caffeine or alcohol late in the day that might interrupt your sleep. Trying to go to bed at a regular time to create a healthy sleep pattern. It's always important to encourage patients to exercise regularly. And obviously that exercise needs to be adapted to what is physically possible. But getting outside for fresh air and having a walk can often be an important part of someone's day. And then also looking at the medication you're on and the impact that it might have in terms of your energy levels. This is really important to talk with your medical teams about. Certain medications can increase the risk of fatigue. So particularly drugs like thalidomide have a sedative property, and it's important that they are taken at the end of the day, just prior to going to bed, rather than early in the day, where they may cause daytime fatigue. Next slide, please. Moving on to infection. You're probably aware that myeloma patients have a higher risk of infection, and obviously that's been at the forefront of everybody's mind over the last year, particularly with the COVID pandemic. It's forced many patients to have to shield as a result of trying to reduce the risk of infection. Why does infection occur? Well, there are two main reasons. The myeloma cell, which is a blood cell, is important in the immune system in producing antibodies against infection. And in myeloma patients, the immune system is suppressed, and as a result of this, the risk of infection is increased. Many myeloma treatments can also reduce the level of the white blood cells, which are also needed to fight infection. As well as catching an infection, myeloma patients may be also at risk of opportunistic infections, and therefore it is important that they're aware of this. Next slide, please. I'm sure that many of you as patients have been warned by healthcare professionals to look out for signs of infection. This is particularly important when you're on chemotherapy treatment. The signs of infection might include a fever, particularly a temperature of over 38, or a persistent temperature of 37.5 with symptoms, a persistent cough, chills or sweating, unexplained nausea and vomiting, a new rash, or the development of redness or swelling in the skin or the limbs. It's important to recognize these signs of infection, and if worried, to contact a doctor or nurse. And we always stress to patients that it's really important to do this, even if it is out of hours, because it's important that we pick up infections early so that we can optimally treat them. Next slide, please. So what can you as a patient do to try and reduce your risk of infection? So as I say, self-help. Obviously keeping your hands clean, washing them with soapy water and using hand sanitizing gels, as we've all been encouraged to do, particularly over the last 2 years. Also keeping up to date with vaccines. So as well as having your COVID vaccination, so we've encouraged patients obviously to have the COVID vaccination. They should have had the initial 2 vaccinations, a more recent 3rd vaccination, and are also entitled obviously to have a booster vaccination. They should also have the annual influenza vaccination and the 5-yearly pneumococcal vaccination to reduce the risk of pneumonia. It's important to be careful in situations of increased risk. So particularly going into crowded places, I always explain, I work in London, so the London Underground is probably what I would say an increased risk area. It's an enclosed space and it's highly crowded. So if you're having to use or go into places that are crowded, it's important to take as much precautions as you can to reduce that risk. And then it's to remain vigilant for signs and symptoms of an infection. Next slide, please. If you develop low blood counts, what might be causing that? These are very common, particularly as we go through, or as patients go through their disease. And it's usually a combination of factors. For one, as we go further on through the disease, with patients with myelomas, bone marrow function can often deteriorate. And this may partly also be due to the effects of treatment, the effects of previous bone marrow transplantation, which might have an impact on the bone marrow reserve, and also the effect of other factors such as renal function, which can inhibit the production of blood cells, particularly red blood cells, and the effect of other reversible causes. When we are looking at a patient's blood count and we can see that it is falling, what might we be doing? Well, one, we would be reassessing their myeloma disease and looking at particular treatments that they're on to see whether they need to be modified or dose adjusted because of the blood count. We might look for other reversible causes such as a low iron or low vitamins that might be affecting the blood count. We could use either correction for anemia. We could use drugs such as erythropoietin, which is a hormone which stimulates the production of blood cells, or we might give a blood transfusion. If patients have low white blood cells or neutrophils, we might sometimes give injections such as the growth factor GCSF, or occasionally we might need to reduce the dose of the chemotherapy treatment or have an interruption of treatment to allow the blood count to recover. Thrombocytopenia can often be more troublesome, partly from the fact that platelet transfusions, although can be given, are short-lived in its effect. Often we have to interrupt or modify treatment if people are getting recurrent problems with thrombocytopenia. Next slide, please. Pain is very common and is also very personal and subjective. One person's pain can often be very different to another person's pain. And it's very important to listen when someone is talking about, obviously, their pain, so that you can actually effectively manage it. These are two good ways of describing ways patients have described their pain. My pain is constant and unrelenting. It gives me the feeling of isolation that no one apart from me and my husband can understand. It is a daily battle to keep focused. Or pain is the constant daily grind, limiting me physically at work and in social terms. You learn to cope with it, but it's hard for other people to really understand what you feel. Next slide, please. So when we're looking at a patient's pain, it's really, really important to try to work out the underlying cause for it. There are many causes that might be related to the myeloma itself, particularly underlying bone disease. And that might be historical underlying bone disease or active new bone disease. Then we also need to look for peripheral neuropathy. And certainly later on in the disease pathway, many patients will have received medication in the past which may have contributed to peripheral neuropathy, particularly drugs such as Velcade, which we know, is commonly associated with causing peripheral neuropathy. Sometimes also patients may have other underlying reasons for peripheral neuropathy. So they may be at greater risk because they have conditions such as diabetes, or they have, have other reasons such as within their myeloma, they have associated amyloidosis, which may cause peripheral neuropathy. So again, we need to look at it at an individual level and work out what is the underlying cause. There are also other causes of pain that patients may experience. Pain may be secondary to infection, mucositis. Constipation, I would say, would be a very common complaint or alteration of bowel function associated with pain, abdominal pain. And obviously the other one that's very common for patients would be pain secondary to our bone marrow tests. Next slide, please. When we're looking at managing pain, we need to look at, as I say, the underlying causes so that we can direct the appropriate treatment for that pain management. Pain, if it's related to the underlying myeloma, may be relieved by us actually treating the myeloma itself. We need to target the painkillers according to what we think is causing the pain. There are specific painkillers for particular types of pain. So peripheral neuropathy, we will use painkillers that are much more associated with nerve pain as opposed to the opiate type painkillers, which we more frequently will be using in bone type pain. We need to look at the best way of delivering that painkiller and appreciate that some patients will find different formulations easier than others. So there are tablets, liquid, patches, or injections. And so discussing that is a very important part of trying to optimize pain management. Sometimes, if there is localized pain, particularly bone pain, we may consider some local radiotherapy, which can be very effective. And then particularly in patients with spinal disease and problems with vertebral compression fractures, we may need to look at discussing the patient's case with our spinal team or spinal orthopedic or neurosurgical teams to see whether any surgical options might be a good option for pain management, particularly procedures such as kyphoplasty, where cement is put into the vertebral bodies to stabilize the spine and also reduce pain. Next slide, please. So as I mentioned, peripheral neuropathy is extremely common. Obviously, the symptoms that a patient experiences can be very different. So one of the important things is, as a clinician, is for us to listen to patients when they are reporting symptoms and realize that actually one patient's way of reporting peripheral neuropathy can be very different to another person's way of reporting peripheral neuropathy. It can often be described, particularly peripheral neuropathy in the feet, that they feel like people feel like they're walking on pebbles, that they have difficulty in knowing where their feet are. And that's very relevant when you're talking about function, because obviously if you're driving a car, it's important to be able to locate where your feet are in terms of pressing on pedals. And if you're coming downstairs, it's important to be able to put your feet very safely on the stairs to avoid falling. Altered sensation in the hands can equally be very different in different patients. It might be that you're getting intermittent tingling, pins and needles, but also we look out very much for pain or functional impairment, which is really important to avoid. And obviously what we want to be doing is to avoid patients getting very advanced problems with peripheral neuropathy, which is affecting function. So it's possible that if you're on treatments that might be precipitating the symptoms of peripheral neuropathy, we might need to look at changing the doses of those treatments or potentially stopping them. Next slide, please. So management of peripheral neuropathy, as I say, can be a change in dosage or treatment. It can be by us using specific neuropathic drugs which target particularly bone pain, and that might be drugs such as amitriptyline or pregabalin or gabapentin. Occasionally, patients find drugs such as quinine helpful, particularly more for cramp, I would say, than peripheral neuropathy. They might use local anesthetic patches for local relief or TENS machine for pain relief. But as I say, it's about discussing with individual patients what those symptoms are and trying to optimize the pain control in whichever possible way is possible. Next slide, please. Obviously, living with peripheral neuropathy is something that many patients, unfortunately, have to live with at some point in their myeloma journey. As I say, we try to avoid significant peripheral neuropathy, but in some patients, they do develop quite significant problems. As well as using analgesia, it's important to look for other methods of helping with peripheral neuropathy. And certainly alternative therapy such as massage or reflexology, or certainly we've had some success with clinical hypnotherapy, can help with the symptoms of peripheral neuropathy. There might be topical creams such as menthol creams or capsicum, which can sometimes help. Patients sometimes find either hot water bottles or cold ice packs can relieve their symptoms. It's very important if you have numb feet to make sure that you have well-fitting protective shoes, because obviously there is a risk of developing problems with your feet if you're not aware of the fact that obviously shoes, if they're not fitting well, could be rubbing or cause blistering or cause problems without you necessarily being able to feel that. And equally, when you're running a bath, I always say to patients to make sure they're very careful to make sure that they feel the temperature of that bath using another part of their body before they put their feet into the hot water. And then sometimes using vitamins or supplements, so particularly vitamins like vitamin B, can sometimes be of use or help. Next slide, please. But I think we all appreciate that living with pain can be very difficult. So it's really very important to be honest about the pain you're experiencing and asking for help when you need it. When painkillers are prescribed, it's important to try to take them as they are prescribed and regularly. So one of the difficulties can sometimes be when people are taking painkillers sort of intermittently or erratically, is that you get peaks and troughs with pain, and as a result of that, the control can be suboptimal. Trying distraction or relaxation techniques to try and focus on other things other than the pain can sometimes be helpful. And as I say, sometimes complementary therapies may also help. And we often, within our team, will make a referral through to the palliative care team, because they are experts in pain management and will often give us some very helpful and useful advice for patients. Next slide, please. I thought it's probably useful to talk about osteonecrosis of the jaw, since certainly in the later stages of myeloma disease, it can occur. And if we look at patients on bisphosphonates, approximately 10% of myeloma patients can experience osteonecrosis of the jaw. We know that the risks of getting osteonecrosis of the jaw are associated with invasive dental procedures, with prolonged use of bisphosphonates, and with the intravenous bisphosphonates. Now, we do use intravenous bisphosphonates because equally we know from big clinical studies that the intravenous bisphosphonates have a better effect on the bone health of myeloma patients, and particularly reduce the risk of progressive bone disease and bone fractures. But we have to balance the risks and the benefits for patients, and it's important that we do that. So what can we do to help with that? Well, it's very important is prevention. Good dental care is essential. At baseline, patients ideally should have a dental review, which will pick up potential future problems with their dentition that might be managed right at the beginning of treatment. Throughout treatment, it's really important that ongoing good dental care is continued with regular visits to the dentist. And if there is any need for any invasive dental procedures, we would recommend that you discuss that with your healthcare team at the hospital prior to proceeding to an invasive dental procedure. So that includes dental extractions or root canal treatments. So I certainly know in our local practice, we recommend that all our patients actually have any invasive dental procedures done within the hospital. It's also important to remember, even if you don't have any teeth, well-fitting dentures are also essential, because sore areas due to poorly fitting dentures can also end up causing osteonecrosis of the jaw. So it's important when you see your clinician that you report sore areas or exposed areas in the mouth to the healthcare professionals so that they can examine your mouth and, if need be, refer you through to the dental teams within the hospital for review. And as I said, always discuss any dental treatment with your medical team before proceeding. Next slide, please. Okay, so moving on to complications occurring later in the disease pathway of patients. Some of these overlap with what we've already discussed, but this really falls into bone disease, renal disease, low blood counts, extramedullary disease, and refractory disease. Next slide, please. So myeloma bone disease is very common. 90% of patients will have some form of myeloma bone disease at some point in their treatment pathway. Myeloma cells effectively cause bone disease due to local damage at the site of the disease within the bone marrow. And that leads to thinning of the bones and potentially holes in the bones. And when the bones get to a certain point where they are thin, they might fracture or break with very little insult. This can affect all of the main bones in the central part of the skeleton, so the spine, the hips, the ribs, and the long bones of the arms and legs. Next slide, please. What is the impact of that? Myeloma bone disease can cause pain and discomfort, and that may be due to damage to the bones, which can cause chronic pain. It can also cause breaks or fractures in the bones where the bones are thin, and it can cause problems such as hypercalcemia due to the release of calcium into the blood, which can be associated with confusion, thirst, and other symptoms. I think importantly, particularly in patients who are in later stages of their myeloma disease, long-term problems in terms of loss of height due to fractures in the spine are very common. And this can cause long-term problems in terms of pain, because as the normal posture is affected by fractures to the spine, it can cause increased pressure on certain muscles, so that although patients may not have an active fracture, they may also have muscular pain around their spine. It can also lead to a curve in the spine, causing difficulty in breathing and reduction in mobility. We also have to remember progressive spinal disease can also be associated with sudden problems such as neurological problems. And so that if patients complain of back pain, we'll also take it very seriously to make sure that there's no associated neurological compromise, so compromise to the nerves, and may need to investigate this further with an MRI scan. Next slide, please. So how do we treat myeloma bone disease? Well, as I mentioned to you, bone disease is often associated with active myeloma, and the most effective way of treating myeloma bone disease, therefore, is to treat the underlying myeloma disease. We also treat patients right from the beginning of their myeloma journey with the drugs bisphosphonates, so that's Sameta or permethrinate, and this basically acts in the bone, it prevents further risk of bone damage. And we know from big studies that use of bisphosphonates reduces the risk of progressive bone disease and bone damage in patients with myeloma. And then finally, we need to focus on managing the symptoms, and that could be with painkillers. As I say, local radiotherapy can often be very effective for painful bone disease. Surgical interventions, particularly if the bones are weakened, and we need to try and stabilize those areas where the bones are weakened with either putting in some metal work or cement. And then more non-medical self-help ways of managing bone symptoms and pain. Next slide, please. Myeloma in the kidney. At diagnosis, approximately 20% of patients will have kidney disease, and during a patient's pathway, up to about 40% of patients will have significant problems with their kidney. Next slide, please. What causes those problems? Well, the myeloma disease, particularly patients that have high levels of abnormal light chains, can affect the kidney function, since the light chains are deposited often in the tubules of the kidneys, causing inflammation and problems with the kidney function. Myeloma also is associated, which we mentioned, particularly with when patients have significant bone disease with high blood calcium, and that can lead to dehydration. And high calcium and dehydration increases the risk of myeloma kidney disease. And then many of the drugs that we give are also potentially can contribute to problems with the kidneys. What symptoms might patients have if they are developing kidney problems? Well, often actually patients may have no symptoms, but symptoms that could occur include fatigue, loss of appetite, breathlessness, fluid retention, so swelling in the ankles and feet, and potentially headaches. And how would we treat patients with myeloma kidney disease? Well, actually, the main way of treating myeloma kidney disease is, particularly if it's come on suddenly and is rapidly deteriorating in terms of kidney function, we would want to treat fairly rapidly with high-dose steroids and chemotherapy treatment, since it is the underlying myeloma that is causing that. We'll encourage patients to drink plenty of fluids to try and keep the kidneys well flushed. But a proportion of patients may need dialysis, and if they need dialysis, particularly in the latter stages of disease, it's possible that that may be an irreversible process and they may need to continue with dialysis long term. Next slide, please. Some of you may have heard of the term of extramedullary disease. So myeloma normally is a disease which is found within the bone marrow. The reason being that plasma cells, which are the cancer cell in myeloma, the normal site in which those cells are found in the body is within the bone marrow. In the latter stages of myeloma disease, sometimes the disease develops outside of the bone marrow. And when myeloma develops outside of the bone marrow, we call it extramedullary disease. Now, when that happens and you get myeloma within either other organs or in soft tissue, complications might arise as a result of the site of that tumour. So, for example, if you were to develop myeloma in the skin, you could get problems with ulceration of the skin or a visible lump in the skin. If you get myeloma affecting the tissue around the side of the spine, but not actually the bone, it could cause compression of the nerves. So we have to manage that according to the site in which the complication occurs. Extramedullary disease is often associated with a more aggressive tumour, and is often less responsive to chemotherapy treatments. And as I say, that is often why we see it in the latter stages of myeloma disease. And of course, we have to make a decision about the most appropriate treatment according to what patients have received previously in terms of their treatments, and what is most likely to be the most effective disease treatment. Next slide, please. Finally, we need to talk about refractory disease. So as many of you will be aware, myeloma is a disease in which patients have periods of relapse and periods of remission. With each period of relapse, we would plan to focus on trying to treat the disease to get it under control and hopefully achieve a remission once again. In late stages of myeloma disease, despite treatment, the patient's disease may not respond. And it's at that point that we call it refractory. And it means that it's no longer responsive to the treatments that we have previously been used. At this time point, our options may be more limited. Often by this time point, patients have already received a number of lines of therapy. And what's really important is to have discussions around the importance of quality of life, really getting our symptom control optimized, and potentially advanced planning. Those discussions are vitally important, and it's really, as I say, an important discussion between the healthcare team, families, patients, and the nurses. Next slide, please. So hopefully we've covered quite a lot of areas. There will, I'm sure, be lots of potential questions, and we can have a question and answer session. I think I'm passing over to Suzanne once again.
Yes, thank you, Fenella. There was lots of valuable information there. And like you said, we're now going to move on to some questions. So thank you to all those of you who pre-submitted questions, but we've also had some live questions. So we're going to start with a couple of live ones. So first of all, a question from Zach. Fenella, you mentioned opportunistic infections. What are these?
So opportunistic infections. So we always have the risk of getting infections from bugs within our own body. So I always say to patients, it's not just about you catching an infection from someone else. And a good example will be if you have mucositis, the integrity of your lining of your gut might be compromised. And as a result of that, the gut, which is full of bacteria, might those bacteria might leak into your bloodstream as a result of that. So it's an infection that you're carrying, or potentially a risk of infection you're carrying yourself, because of the fact that everyone has bacteria in their gut. Now it wouldn't normally be a problem, because obviously without treatment you wouldn't have had that breakdown of the mucosa of your lining of your gut. But it has occurred because of the fact that you're having treatment, and that has increased your risk of getting that infection.
Okay, thank you. We also have a question from John. So he asks, at what point would you stop reporting a high temperature to your myeloma team and go to the GP instead? So for example, is that what you would do if you were in remission?
That's a really very good question. So anyone on chemotherapy treatment, we would always recommend that they report a fever to their doctors and nurses. That's really, really important. You're absolutely right. If you are in clinical remission and you get a temperature, and we know at that point that your blood count is normal, there may be many instances where you don't need to have a call to the medical team immediately, and that you can go to your GP. So it is a sort of balance, really. Definitely on chemotherapy, we'd definitely recommend that you would always come through to the hospital and the medical team to discuss that first. They may say, having had a discussion with you and looking at your blood results, that actually they don't think there's anything that needs to be done and that you can go and see your GP. That's fine, but I think you should always come through to the hospital if you're on chemotherapy treatment.
Yeah, that sounds very important, Vanessa. Thank you for that. So the next question is, can you explain how myeloma cells change over time and the impact? Does that affect a patient's treatment or prognosis?
Yeah, so that's a very, very important question as well. So myeloma, the way I sometimes describe it to people is that myeloma is not just one single clone of abnormal cells. So if you think of myeloma being a group of clones, and that at the time of diagnosis that you have a dominant clone which is causing the disease, which we then are treating, okay, with our treatment, and that comes under control. But at the point of relapse, a separate, slightly different clone becomes the dominant clone, which does not respond necessarily to the treatment we previously gave, has a slightly different signature, as it were. And that responds to a different therapy. But as you carry on through the disease, what often happens is that the disease becomes more resistant because it's had prior exposure to different medication, which has driven a more resistant clone that doesn't respond to the drugs so well. And equally, as the disease progresses, sometimes the genetics, the background abnormalities in terms of the genetics does increase as well. So it becomes a more complex disease and a more resistant disease with progression.
So next we have a question from David. Having been in remission for a long period following a stem cell transplant, would there be any benefit in taking a maintenance drug like lenalidomide?
That's a very good question. So most of the clinical trials for, obviously, lenalidomide is now recommended for patients after autologous stem cell transplant, so the first stem cell transplant. And that's based on the big study that was done in the UK, and then also similar studies done internationally, in which patients were given lenalidomide at the time point of their disease being under good control. And I think that's very important. Obviously, you're choosing a time point after transplant where hopefully the disease is at its optimal control. We don't give it, obviously, if there's signs that the disease is progressing again. Obviously, we haven't done the big studies to look at if someone is being in remission for 5 years, whether they would benefit from lenalidomide. And so that's a difficult one to say. But actually, in many ways, the fact that if someone's had stable disease for a 5-year period, it's very likely that their immune system is sort of regulating any residual disease that's present at that time. So we're not recommending, obviously, that everybody gets maintenance lenalidomide, particularly if they've been stable for a long period of time without any intervention at that point. It is very much for patients in that first treatment pathway after an autologous stem cell transplant, when their disease is well controlled, to try and sort of maintain the response that has been achieved.
Mm-hmm. And a popular question that we get asked a lot, what are the long-term effects of a stem cell transplant?
Yeah, so that's very important, obviously, in terms of looking at the shorter long-term ones and the ones that we can see sort of very much more in the future, as it were. So after a stem cell transplant, in the first few months, obviously, the main things that we often see can be reduced blood count and suppression of the immune system, so risk of infection. But longer term, some of the things that might be relevant is, one, as I said to you before, is some patients do have a reduced bone marrow reserve. And that can be sort of important, particularly when it comes to future treatments. So if they've had a suboptimal recovery of their blood count after a stem cell transplant, when it comes to the disease progressing again, that might have an impact in terms of the options of treatments that are available at that next time point. The other thing that we can see is obviously the medication melphalan is a strong chemotherapy drug which does affect the DNA of cells. And so we do know that in patients that are given chemotherapy treatment and also myeloma treatments, that there is a risk to the bone marrow in the future. So some patients may develop later in their disease a problem with the bone marrow. So we look for problems such as a myelodysplasia. This is where the bone marrow function doesn't function normally. The blood cells aren't being developed properly. And that might be a secondary effect, like a secondary cancer, secondary to the previous high-dose melphalan that is given with the transplant. So that can have an impact long term. Other things that might be a longer term issue is obviously when we're giving high doses of chemotherapy is effect on fertility. So that will always be a discussion that is had, particularly in someone that is a younger, in terms of planning if they might want a family in the future, and doing sort of things in such as egg preservation or sperm collection prior to transplant. So there are a number of short-term and longer-term things that has to be considered.
We've also had a few patients ask, can you offer some advice on the long-term use of treatment on the digestive system, particularly chronic diarrhea and constipation?
Okay, so I think if you're getting chronic diarrhea and constipation, we probably have to do a number of things. Number one is make sure that there's no link to your underlying disease, myeloma. So particularly patients that have this condition, AL amyloidosis, can get effects on the gut and could impact on the gut. The next bit is to look at the treatments that you're on. So treatments for myeloma can affect the gut quite a lot and cause diarrhea or constipation. So particular ones to note is thalidomide is very constipating, so patients often experience problems with constipation. Lenalidomide, when used particularly long term, can cause an effect on the bile salts and cause bile salt malabsorption and cause chronic diarrhea and problems with digestion. And then drugs such as painkillers, so particularly things like morphine can affect the gut and cause constipation. So there's a number of things that might be contributing. So I think it's always important to try and work out what the underlying cause is most likely to be related to. And then I often find that one of the problems with diarrhea and constipation intermittently happening is often in relation to how sort of laxatives are taken as well. So making sure sometimes having a small amount of laxative on a regular basis rather than intermittent strong laxatives, which can sometimes cause this fluctuation between diarrhea and constipation. So there's no straight answer. I think it's trying to look at what might be triggering it and trying to get a regime that seems to get a bit more stability in terms of bowel function.
Okay, thank you. And just to say to everyone, please stay online. We will be going on for a little bit beyond 6 o'clock. So the next one is a question from John. Can bone pain be felt even when in remission? And how could this progress over time?
So bone pain can happen even in remission because, so if I take an example, if you as a patient presented initially with fairly significant bone disease, so that could be particularly, let's say, bone disease in the spine, and as a result of that bone disease at diagnosis you had some what we call compression fractures where the vertebra in the spine have collapsed partially. and it's caused some changes in your posture, it's very, very possible that you can have ongoing, I would say, musculoskeletal pain. So it might not just be bone pain, but it might be muscular pain as a result of that change in the structure of your spine. So yes, you can get long-term problems with pain as a result of previous bone damage. Obviously, it can progress. So one of the things we're using your myeloma treatment and bisphosphonates for is to try and reduce the progression of bone damage that is done by the myeloma. And we do know, obviously long-term, the use of bisphosphonates will really help with that. And it can be very important to look at other mechanical things that might be important. So, certainly if you've got significant spinal disease, having that reviewed to assess whether there are any other interventions, such as spinal interventions, that might help in terms of that bone disease and progression.
Thank you. So then we have a question from Ian. Is there a test to show how compromised our immune system might be?
So yes, if we are looking at, so when you have your regular blood tests at the hospital, so they will be looking at your paraprotein or your light chains or your Bence-Jones protein. When they do your paraprotein test, they also look at your immunoglobulins. So these are the normal proteins that are produced by plasma cells. All people will be producing these immunoglobulins, and in myeloma patients, they also produce immunoglobulins, but also have this abnormal immunoglobulin, which we call a paraprotein. So if you've got myeloma and you're on treatment, particularly, often the background immunoglobulins are suppressed, and often that is indicative of you having an increased risk of infection. It's what we call a secondary immune paresis. Now, the difficulty is that it's not always a sort of linear effect. So if you've got very low immunoglobulins, you are definitely going to get infections, because there seems to be more to it than just measuring levels. But what we can say, if you have very low immunoglobulins, you are likely to have a higher risk of infection.
Okay, so the next one is from Mary. As my body tries to accommodate treatment every month, what is the likely long-term damage and deterioration? How can I best be aware and be prepared for future challenges?
So that's a good question. So obviously Mary, in terms of the symptoms that she's getting, it all depends a little bit in terms of the treatment that you are on, because every treatment has its own potential profile of side effects and toxicities. And I think, therefore, the symptoms that a patient experiences can often be very individual and related to whatever treatment that they're on. So it's really important that when you're on treatment, that on the regular basis, when you see the nursing team and the medical team, is to really describe to them the symptoms you're getting, to help for those symptoms to be controlled and managed as appropriately as possible. Obviously, going forward, I think people's symptoms, again, it's very individual. So it's a combination often, not just purely of the treatment, but what's happening with the background myeloma disease and the burden of that. What other toxicities or problems may have happened, either due to previous treatments or to the myeloma. So whether there is other problems such as kidney disease or bone disease. So I think it's a combination of factors, and I think you have to look at all of those things in terms of what the likely impact is going to be in the future. And it's very difficult sometimes to predict that, actually, to a single time point, because things can change over time. and problems can arise or can resolve over time. So it's a little bit difficult to be very prescriptive about exactly what to expect in the future, but I think probably the talk that we had today covers some of the more common things that might be experienced by patients in the future.
Okay, thank you. So we're going to squeeze in one final question, and that is, as I'm taking pain relief medication, should I be worried about addiction?
That's a very, very common question that I have. So often people are very, very anxious about taking particularly opiate type medicines. But equally, what we're trying to do with any medication in terms of pain relief is to make sure that we always focus on quality of life and to be in pain, sort of intractable pain, without having that managed appropriately is not going to enhance the quality of your life. So I think it's very important that if there is significant pain, that the focus is on managing that pain with whatever medication is required. Now, the next stage is when someone, maybe has just finished their treatment or has gone through their treatment and their pain is getting better, that the doses of those medications are titrated down to try and see whether actually it's possible potentially to come off those treatments. It may be possible to come off the pain medication. So it's not a fixed process. You don't start opiate medication and never stop it. It's always a dynamic picture, and obviously if the symptoms have improved to a degree where you feel that you don't need that medication, obviously we would always look at trying to reduce the dose to the level that is the minimum level that is needed.
So thank you, Fenella, for your comprehensive answers to those questions. So now we're moving on. So I'd like to highlight some of our Myeloma UK resources that you might find helpful. We have a series of info packs and info sheets that explain some of the topics that have been mentioned today, and obviously I see they've been coming up in the chat. So please head along to the Myeloma UK website to access them. We also have our Myeloma info line and Ask the Nurse email service. Our information specialists are available Monday to Friday, 9 till 5 p.m. As well as the info packs and info sheets, we also have a range of publications that you can download from our website, or you can order a selection of hard copies. All our Digital Infoday sessions are up on our website and also on our YouTube channel, so you can watch them on demand. And this also includes a range of online videos. We have our online discussion forum that you can join, where you can maintain regular contact with patients and families experiencing myeloma and its related conditions. Lastly, we have a range of support groups all over the UK. So even during the pandemic, some of them are meeting face-to-face and some are meeting virtually. So please get in touch if you would like to join one. So I'd like to hand back to Fenella to sum up our take-home messages.
Thank you. So there are three, I say, take-home messages. These are the same messages that we had at the beginning of the talk. So importantly, to say more myeloma patients are living for longer due to better treatment and management. Longer term, myeloma causes complications as a result of the build-up of treatment side effects and changing of the myeloma disease. But really importantly, please, 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 talk to your healthcare teams about these complications, because they can be managed, and it's really important to report any new symptoms or side effects to your teams. Thank you.
Okay, so we've come to the end of our webinar today. Thank you so much to you, Fenella, for speaking and answering our questions. And thank you to everyone who has joined us this evening for this webinar. We hope you found it helpful and informative. I know I certainly did. If we didn't manage to answer your question, or this has brought up some new questions, please do get in touch with us. You can do this via our info line or our Ask the Nurse email service, details of which are on the screen now. You can rewatch this webinar on our Facebook page, and it will be available on our website soon. Thank you to you, our supporters. Myeloma UK is able to provide free digital events like this one for patients and their families. If you'd like to support the work of Myeloma UK, please visit our website on www.myeloma.org.uk/donate. Keep an eye on our website and social media channels for announcements for further Digital Infoday sessions, which will be taking place next year. Once again, I'd like to thank you for joining us, and I hope you enjoy the rest of your evening. And since it's the 1st of December, I'll wish you a Merry Christmas, and thank you and good night.